Martina Kashengi. She is the Technical Director of CAP TB Project and the Pediatric AIDS Foundation. So the floor is yours, Martina.
Hello, everyone. Thank you very much again for the invitation to participate to this event organized by MSF. I've been working with MSF for more than 12 years and MSF is still family, is still close to my heart. So I'm really pleased to be here and participate to this event. So if you go to the next slide. So I will present you today some experience and data from the CAP-TB project that is a Unitaid funded project implemented by ECPAF. The project is implemented in 9 African countries that you can see in the map here and in India. The 9 African countries are Cote d'Ivoire, Cameroon, DRC, Kenya, Lesotho, Malawi, Tanzania, Uganda, and Zimbabwe. If you go next slide, please. So the CAP-TB project is focusing really on children 0 to 14 years. This is the main target population for the project. And it has 2 main objectives: to improve pediatric TB case finding and improve access to TB preventive treatment for children. You see here in the table below a summary of the key timelines for the project. The programmatic implementation at site level kicked in Q4 2018, and the project is coming closer to an end. So the programmatic implementation at site level is scheduled to be completed by September 2021, so this year, in a few months. And we just got a no-cost extension by Unitaid, but this will serve only to the purpose of finishing the 2 randomized studies that are included in the project. If you go next. So when it comes to the case finding approach, this is what the project has has implemented in across the countries. I will focus my presentation primarily on the African countries because in India, the project focused more on the private sector, so it deserves a separate discussion. So across the 9 African countries, this is the approach that we have implemented for improving case finding. We implemented household contact investigation, either at community or at facility level, and we will talk more about this in the next few slides. We also implemented an intensified case finding at facility level, focusing on different child health entry points like maternal and child health, OPD, nutrition, HIV, pediatric wards services. The focus of the project was on, in terms of settings, was on district or sub-district hospital level facilities and primary healthcare facilities. So in order to intensify the case finding, we introduced the pediatric TB specific symptom-based screening. So we developed a set of standard questions that were administered either at triage by the triage nurse or in the waiting group by community healthcare workers. The children identified as possible presumptive TB through this standardized set of questions were then referred either to the clinician or to the TB nurse to confirm the presumption of TB and to them being referred for further TB diagnostic investigations. The backbone of the project was really to have a strong pediatric TB training, as well as support and supervision, with also a strong focus on capacity to clinically diagnose TB, because we thought that this was the key weakness when we started implementing the project. Next slide, please. So when it comes to the TPT interventions, the TB preventive treatment interventions focused on 2 main populations: the children living with HIV and the child contacts. And again, this will be the focus of the next few slides. When it comes to the child contacts, the priority populations for TPT were the children 0 to 4 years, because basically, despite WHO recommendations already recommending TPT for all for contacts of all ages, we really wanted to first get the high priority population covered by TPT. And the starting point that we was really low in terms of coverage of TPT. We really decided to focus first on this population. So Community-based household contact investigation was implemented whenever feasible. The targets were children 0 to 14 years. All children found in the household were screened. Asymptomatic children were either 0 to 4, irrespective of HIV status, or above 5, but with HIV positive status, were referred to facility for final assessment and initiation of TPT. And on the other side, also symptomatic children were referred to the facilities for further diagnostic investigations. In few selected countries, we introduced the use of the 3 months rifampicin isoniazid regimen, because as many of you know, we now have a pediatric fixed dose formulations for RH, and this is exactly the same formulation that is used for the continuation phase of the drug-sensitive TB treatment, so it's already available in most countries, and it has the big advantage of being dispersible and with a child-friendly taste. So we, whenever possible, we switch to this shorter TPT regimen that has been recently recommended by WHO. Next slide, please. So I will go very quickly through this. It's just for your reference, but just for you to know that the data that I'll show you will cover the period between December 2018 and December 2020. Please go next. So starting from the contact investigation and TB preventive treatment. Go next. So this is what we have done in terms of models of care that we try to implement. So we, in each of the country, we really aim at identifying sustainable models of care that could then be carried over once the project was ending. As you can see in this table on the left, there is a summary of the different models of care that have been implemented. Other were, in some countries, it was primarily facility-based models, and in other countries, it was a mix of facility-based and community-based model. And when it comes to the community-based model, in some countries, we had to introduce really the collaboration with a civil society organization that was really in charge of leading the community-based contact investigation activities, while in other countries, this was done through strengthening existing cadre of community healthcare workers that were already present and attached to the facilities. The green tick highlights all the countries where the project had to reinforce the available cadre or system that was in place to do contact investigation, because the available resources were not sufficient to carry out these activities in an efficient way. So as you can see here in the right, you have a bit of a summary of the community-based interventions that were implemented in the different countries. And you can see there is quite a variety in terms of the coverage of the community-based contact investigation that was achieved in the different countries. Overall, across all countries, 76% of the children of the child contact screen were reached through community-based interventions. Next, please. And this is an overview of the cascade. Basically, during the period between December 2018 and December 2020, about 31,000 child contacts were screened. And you can see in blue the 0 to 4 years, and in orange the 5 to 14. So about 50% in each age band. Out of those, about 13,300 were identified as eligible. And the vast majority were the children 0 to 4, because, as I said, these were the main target population for the contact, for the TPT eligibility. And about 98% of those were initiated on TPT. So overall, the uptake of TPT was rather good. When we look at the outcomes of the TPT treatment, by December 2020, among all children that were started on TPT, about 8,800 were expected to have reached treatment outcomes. And out of those with expected treatment that were expected to have completed treatment, actually we had recorded outcomes recorded completed outcomes for 8,047, so 91%. So again, there was a good TPT completion that we observed. In few countries like Cameroon, Kenya, DRC, and Zimbabwe, we piloted the introduction of 3RH, as I mentioned. And you can see here the different completion rate of the TPT regimen between the 6 months INH and the 3RH in those countries that piloted in few sites the 3RH regimen. As you can see, the treatment completion with the 3RH regimen is slightly better. Next slide, please. So, and this is a pre and post comparison. So what you can see here is across the 9 African countries, a comparison between average monthly rate of TPT initiation at facility during the pre-intervention period, so during the baseline, and during the intervention period. As you can see, the initiation of TPT improved in child contacts, improved across the vast majority of countries. And overall, across all countries, a 4.4-fold increase in the number of TPT initiations per facility was observed. And across all countries, 72 sites were newly capacitated to provide TPT services during the intervention. Next slide. So in conclusions, what we found is that rollout of TPT services is feasible and technically is less challenging than building capacity for pediatric TB diagnosis. So actually the uptake at facility level and the number of children that were initiated was, the rate of improvement that we observed was much bigger when it came to TPT uptake than when it came to diagnosis, because as we just finished to discuss, diagnosis is challenging. Most challenging aspect was really the effective planning and rollout of the contact investigation activities, especially when it came to the community-based household contact investigation. This indeed requires, dedicated staff and HR. It requires dedicated resources for community health workers trainings, for resources for management and supervisions. And also really it is important to consider reimbursements for food and transportation costs. So these are all really important points that needs to be taken in consideration, that they were forgotten in the setup that we found in several countries being available for contact investigation. Also, we found that the introduction of a contact investigation and TPT registers can be really useful to support, accurate line listing of contacts, as well as monitoring and supervision activities. So even the facility staff is much better equipped to supervise their own contact investigation activity. Next, please. So contact investigation has been confirmed to be a critical intervention for pediatric TB management. And if there will be some time, I will show you that is a key gateway for both case detection as well as TPT. Reaching child contacts is the most challenging part. So it's really important to program and to plan carefully the community-based activities to reach the children. And the 3RH short regimen for TPT is a feasible and valuable option, and in general, for provision of preventive therapy in child contacts, and the uptake at facility again was quite smooth, and feedback from healthcare workers very, very positive. Next. So, this is not really showing as it should, but what I wanted to tell you is that in terms of contact investigation and TPT, there is more information to come from the project. Indeed, the project embeds a clinical cluster randomized trial that is led by Marilyn Bonnet, who many of you may know because she has worked many years at Epicentre. And this study is implemented in Cameroon and Uganda, and is looking at community-based household contact investigation as well as initiation of TPT. So the major change that the study is looking at is really the feasibility of initiations of TPT at household level. And the regimen that is used by the study is the 3RH regimen, and study results are expected by between June and September 2022. So watch this space for more information to come. If there is some more time, I can quickly show you the case finding component of contact investigation. So when we go into case finding, if you go next, I just wanted to highlight that overall, among the total number of cases that were notified, and identified through the project, 11% came from contact investigation activity. So while 89% came from this intensified facility-based case finding. So we found it has been in our hands a very important component also for case finding, the contact investigations activities. And you can see here in the table, the number needed to screen calculations for the different countries. So if you sum up across all the different countries, the number needed to screen is 40. And if you calculated the average of the number needed to screen achieved in each single country, the average is 76. So in both cases, quite an important contribution. And if you go next, very quickly, I just wanted to show you that in terms of contribution of the different entry points that were included in the project, contact investigation is the third one. So the majority of children were found through this intensified case finding at OPD and then at IPD, and then contact investigation comes in the third position. So again, very, very important and relevant contribution. So if you go next, with this, I come to an end, and I would like to thank all the Ministry of Health in the countries where the project has been implemented, all the health facility staff, and all the CAPTB teams at country and at global level. And I'm happy to take questions during the Q&A session. Thank you very much.
Thank you, Martina. There's one question for you in the chat on contact tracing in conflict areas where MSF work. Do you have any short reflections on that to share?
Well, no, in the sense that in our context, there were no conflict. We didn't really were faced with implementing conflict zones. I think we were faced with in Turkana in Kenya, implementing contact investigation activities in a very rural area with nomadic population, and there most of the contact investigation was done through facility because it was really, really challenging to put in place a system for community health workers to reach the different households. So I can tell you that in that kind of particular setting, we had to work to rather strengthen a lot of the facility base with a lot of follow-up to get caregivers to bring the patients, their children back to the facilities, because the community base would have been really not sustainable for the NTP to continue after the project was finishing.